Dr. Montgomery, and here she is, Dr. Montgomery.
All right, thank you, Dr. Khalifa. Okay, so we're in the small bowel. We're going to have some neoplasms, and then I'm going to digress a little bit and talk about a very annoying topic, which is mast cells. I can't move it forward. Oh. Okay, so we're going to discuss some of the common neoplasms we might see in the small bowel. We're going to talk about a couple of non-neoplastic lesions that can mimic neoplasia, and we're going to talk a little bit about mast cell disorders, and then I'm going to show you my dirty laundry. Okay, so this is bread and butter. This is a bump. You can see that the central part of it is a little bit eroded, but basically it looks like it's under the mucosa. So remember, we're in the duodenum. And here it is. And if you're like me, when you first look at these things, you just think it's a bunch of inflammation. How many of you have been down this garden pathway? And does anybody want a special stain, or are you already done with the H&E? Here's a chromogranin. So there was a little well-differentiated neuroendocrine tumor hiding in this sort of junky-looking duodenal mucosa. Definitely, I know my practice habit is if I see sort of junky-looking duodenal mucosa, I do go to high power and scooch around and see if I can find a sneaky carcinoid. And I'm sorry for using the old terminology. So do remember, these can easily be mistaken for inflammation. Here's another such case. Everybody spot it? Right? But it's sneaky. So you have to stay awake. There it is, very easy to see once you're on it. There's also some reactive findings here. Notice that there are gastrofoveolar cells here. They're metaplastic, presumably because that lumpy bumpy is causing an erosion. And here's a chromogranin stain from that one. I don't know about you, but for me, it pops up far more than I appreciated initially. Here's where they're really sneaky. So these carcinoid tumors that you find in the duodenum tend to be very richly vascular and very friable. So you might find you get a little junky fragment like this, and you wonder, oh, is there a little vascular lesion? Why is this so crushed? And this is another sneaky little carcinoid hiding there. So I can tell I see the nodding of people who look like they are somewhat older than 30. Yeah, I've been there, done that. Here's a chromogranin stain from this one, so easy to miss. All right, so now let's get into more fancy schmancy diagnoses. Let's look at a special variant of duodenal neuroendocrine tumor. If you're a resident, this might be on an exam sometime, and that's the somatostatinoma in patients with neurofibromatosis type 1 or NF1. So this is a beautiful example. They love to arise in the duodenum. And here it is, and these are the ones that have the somomatous type calcification. So this is kind of a classic, oh, let's make an exam question out of it type image. And here's this same lesion. You can see the nice neuroendocrine tumor. You can see the somomatous calcification. But of course, that's classic. Here's where it can be a bit of a pitfall. You'll notice that the reference I've given you is from many, many years ago when these colleagues, and I remember Dr. Dial, noticed that the pitfall with somatostatinomas is they tend to make tubules and look like carcinomas, adenocarcinomas, and have a bit of atypia. Here's this one at higher magnification. Notice that there's kind of a sad somoma body, but it really does look like it could be a crushed adenocarcinoma. But then if you think about it, you'll notice that the nuclei are a bit on the small side. And I think this morning, we had a very nice demonstration of how endocrine cells can look very strange when they're crushed and degenerative in our beautiful cytology talk. Here's a somatostatin stain from that case. So very nice confirmation. Notice that there's even a little bit of luminal apoptotic debris in this thing. So really they can be foolers. So in the GI tract, this is a kind of classic appearance of what you might see for an endocrine tumor that's arisen in the ileum. And for reasons only known to it, well, probably a smart person can tell me, you get to see all these very, very dramatic endocrine granules. Notice that they have their orientation so that they're spitting their contents into the little capillaries rather than into a lumen like we might expect with Paneth cells. Here they are at very high magnification. So this little pattern of these outward facing granules is really characteristic of an ileal carcinoid or ileal well-differentiated net. So if you see that in a liver biopsy, it probably came from the ileum. Here's a beautiful example of such a case. This is an ileal carcinoid, or I'm sorry, I'm using old people terminology. And you can see, as we saw before, it's centered right at the junction of the mucosa and the submucosa. But of course, this puppy has extended all the way out to the mesentery. And unfortunately, over 2/3 of small bowel well-differentiated neuroendocrine tumors do present already extending into the mesentery. Okay, so now this is the same picture I showed you this morning, our Zollinger-Ellison patient. And now let's look at it from the small bowel viewpoint. So here we have in the pre-proton pump inhibitor era, this massive oxyntic hyperplasia. Remember, we saw the parietal cells that like to go flipping up into the surface. And here that is at higher magnification. And here's the kind of cute thing. So this is a giant lymph node metastasis, and it was from a teeny weeny baby duodenal gastrinoma. And in fact, if you look in old papers, you can find papers of primary gastrinomas of lymph nodes. No, that's wrong. The colleagues just didn't find the little bitty one in the duodenum. Now we're on to it. This is just higher magnification, so we can see the pretty salt and pepper chromatin. So we'll sort of switch gears a second, use MEN to talk about that phenomenon of Zollinger-Ellison with the teeny duodenal gastrinoma and an associated giant lymph node. For you, those who want to go back memory lane, MEN1 is associated with a tumor suppressor gene, the menin gene on chromosome 11. And you'll remember that the patients get parathyroid lesions, pituitary lesions, and they get, of course, multicentric gastrinomas and ulcers. And of course, PANETs are the leading cause of death in these patients. So this is a beautiful example of a patient with MEN1. And you can see there are arrows pointing to lots of small neuroendocrine tumors in this patient's pancreas. Well, a few years back, actually quite a few years back, Günter Klöpper, who is a pathologist in Germany, he's recently retired, did this sort of survey of all the tumors you would see, these neuroendocrine tumors of the pancreas in patients with MEN1. So notice the color codes and notice his cartoon. There are all these glucagon associated tumors, and let's see, a few insulinomas, you can see those. And then look, there are all these lymph node metastases, and they're all the gastrin guys, but there are no gastrin guys in the pancreas itself. Well, when he flipped over the record to play the other side, he noticed that, oh gosh, all the little tiny gastrinomas were actually in the small bowel and gave rise to these enormous lymph node metastases. So here's such a case. Luckily, we were onto it by the time this came through. And you can see that there's this pretty dainty little tumor, which is completely encompassed in one low power field. You know we're in the duodenum because here's the surface and here are our friendly neighborhood Brunner glands. And here's this tumor and woo, gastrin stain. All right, so I'm obsessed with pyloric gland adenomas. So I must tell you, they're sometimes found in the small bowel. There's always, not always, but there's very frequently little bits and kisses of gastric heterotopia in the small bowel. And from those, you can get any of the gastric lesions that we see. So here's an example of a pyloric gland adenoma. Here's the surface. Here's this lesion, and it looks different from the Brunner glands at low power. Here's our friendly neighborhood MUC6, which of course stains Brunner glands, so that's not terribly helpful. And here's MUC5, which is co-labeling much of the lesion, but not all of it. And there's a lot of gastric mucin cell metaplasia here, so that's staining. So here we are deep into the tumor. We have our pyloric gland adenoma, and entrapped in it are a few Brunner glands. And here's where the stains can help if you're struggling. So this is a MUC6, which stains the lesion as well as the Brunner glands. But the MUC5 does not really stain the Brenner glands, but it stains a lot of the lesion. Here's more of the Brenner glands. You may or may not see one of these in the duodenum. They're not common, but if you do and you're scared, you can use those stains to help you. So now let's get back to reality. Let's compare the duodenal pyloric gland adenoma to a tubular or tubulovillous type 1. So this is a resection from a patient with familial adenomatous polyposis that we've been hearing so much about, but this is not the colon, this is the small bowel. And you can see that there's plenty of small bowel mucosa, plenty of adenomas. And then of course, this puppy has busted out into an adenocarcinoma. A peculiarity of the adenomas that you see in the small bowel, or particularly the duodenum of FAP patients, is they tend to have a whole ton of Paneth cells. And I know there was a paper a few years back that said, oh yes, that's characteristic of FAP. No, 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 no. That is characteristic of small bowel location. So when you see either sporadic or syndromic adenomas in the small bowel, they often have just a ton of Paneth cells, mirroring, of course, the small bowel, which has a ton of Paneth cells, whereas there aren't very many even in the right colon. Okay, but this is real life. We get these little lumpy, bumpy biopsies in which the colleague sees a lesion in the duodenum. And of course, if we call it an adenoma, if we have an overly zealous clinical colleague, we might have a Whipple the next day, and that's not good if it's just reactive rubbish. So there's some clues for reactive rubbish versus adenoma. And the biggest one is looking for this gastric mucin cell metaplasia in a reactive lesion that just happens to be a bit lumpy bumpy. And this case has that. So for me, this is just reactive rubbish, and it's not an adenoma at all. Just for fun, here's a PAS Alcian blue, and you can see the beautiful apical mucin neutral cap of gastric type differentiated mucosa. On the other hand, here's the real adenoma. And at the surface, you will often see lipid that gets stuck. Presumably the lipid is absorbed at the surface because these kind of are small bowel cells, but then they're not quite normal. They're neoplastic, so it doesn't go out the other side. So you get this lipid hang up at the surface, and it can be a very helpful clue. On the other hand, we have an internal control here. Here's some gastric mucin cell metaplasia associated with this lesion. And on a PAS Alcian blue, which you don't need to do, you can see that this stuff isn't mucin, it's lipid. So you can, if you're struggling, actually, you can get some help from just doing a PAS Alcian blue. And here's this kind of business at higher mag with its tandem PAS Alcian blue. Okay, quiz, real or fake? Yes. Okay, so yeah, this is a fake. It kind of looks real here, but it gradually transforms to this stuff that has the surface gastric mucin cell metaplasia. So the smart money is on fake. And here's the gastric mucin cell metaplasia at the top. Notice that there's a sort of basal zone that's like a line underneath the apical mucin cap. Watch that space because you need to think about it when you get mucinous lesions that extend onto the surface. So there's this thing I'm obsessed with that I call the 4 lines: apical mucin cap, base of the cap, row of cytoplasm, row of nuclei. That's really helpful, for example, in Barrett or in antral mucosa in distinguishing dysplasia from reactive. Those 4 lines are your reactivity. Okay, a little side view. We did talk a little bit about traditional serrated adenoma and that it can arise in the small bowel. Of course, I'm in the land of the folks who've written beautifully about sessile serrated adenoma polyp lesion and traditional serrated adenoma. They do seem to exist in the small bowel, and they are much more common than we have noticed. And in fact, they have a very similar profile to that of colorectal traditional serrated adenomas. And you can see them both sporadically in the small bowel and in the setting of familial adenomatous polyposis. My former colleague, Zainab Al-Ruwai, who's now working in Saudi Arabia, and I noticed that in our FAP cohort at Johns Hopkins before I left, that, oh gosh, there are all these FAP patients who seem to have these TSAs, and we thought we were really smart. Oh yes, around 20% of the adenomas of the small bowel in FAP patients have at least a component of what looks like a traditional serrated adenoma. And then she looked at me and she said, well, how about the controls? And I was like, oh yeah, controls. So then we pulled up all the sporadic adenomas of the small bowel. And guess what? We found about the same percentage had a TSA component. So let's see. I guess we did publish that. Oh, just now. Okay, so here's one. Here's a TSA of the small bowel. And you can see it has those beautiful ectopic crypt foci that actually Dale Snover, who's recently, I believe, retired from here, has highlighted with his colleague Emma Torlakovic. So you can see these gorgeous little outpouchings. And of course, that's one of the criteria. Here, this is at higher magnification with this very eosinophilic cytoplasm and these same outpouchings. What I've noticed is that you not infrequently, if you look hard enough in small bowel adenocarcinomas, and granted they're not that common, you will find that the precursor is a TSA. So here's a gosh awful carcinoma in the small bowel. And here is an area that looks to me like it started out as TSA and then, of course, got more genetic hits and has all this nasty high-grade dysplasia. So I've started to notice that more and more as I see small bowel adenocarcinomas. So just going back, adenoma versus reactive, most of the time you can figure it out. But if you can't, do not pretend. Do not make a fake diagnosis of ampullary adenoma and get yourself a Whipple operation if it's just reactive rubbish. If you do not know, make them go back. It's not that hard for them to resample in such a setting. So here's a case that I had that I just couldn't do. So I have this tissue missing here. This kind of looks adenoma-like. This is matured. I don't see my friend, the gastric mucin cell metaplasia. So I just told the truth and said, I'm really not sure. Please go back in a bit. And they went back and there was nothing. Here's that area at higher magnification with which I was struggling. And my friend, the gastric mucin cell metaplasia was not there. Okay, let's look at another thing. It's probably a junior endoscopist saw a polyp in the duodenum and performed a polypectomy. He thought the polyp was very firm and told the pathologist that the pathologist should be diagnosing cancer. So here it is. And sometimes patients will have an accessory ampulla that looks like a polyp. And sometimes a very naive gastroenterologist will actually mistake the ampulla for a polyp and do a polypectomy, which is a very bad idea. But you can see here you have your small bowel coming in. Now you have your biliary type glands and they're kind of extending to the top and there's this sort of disorganized smooth muscle. Well, that's what you got at the ampulla. And here it is at higher magnification with the different components indicated. Okay, so of course, I'm sure all of you, and I certainly have, been through the trouble of having difficulty with the ampulla itself. It's normal to have all that disorganized stuff. And when there's inflammation or prior stenting, be very, very careful. I think anyone who does cytology knows that. And the ampulla is not usually biopsied without a compelling reason. And it's certainly not resected because you can have this pancreatitis that tracks back up to the pancreas and can be very, very debilitating for the patient. So it can be really, really severe to accidentally do an ampulectomy with no good reason. So this is just one of those little mini clamshell biopsies. And this is just ampullary tissue, but of course it looks very disorganized. But notice that it's basically lobulated. So generally you can kind of sort these out. Sometimes you get to see the actual biliary type ampullary cells on the surface without goblet cells, and that's kind of fun to see. Okay, what about small bowel adenocarcinomas? Well, adenocarcinomas are the most common primary malignancies of the small bowel. They account for about up to half of small bowel malignancies, but they're still rare. They only account for 2% of all GI tract cancers and 1% of deaths. They tend to be in older adults. There is a male predominance, and African Americans in our population are overrepresented compared to European Americans. So mostly they're sporadic and they have the same risk factors for colorectal carcinoma. Eating the wrong diet and being overweight and family history. And the rest are syndromic. And they tend to be, as we've heard already today, in polyposis syndrome patients. Mostly FAP, but also in patients with Lynch syndrome, sometimes in patients with Peutz-Jeghers syndrome, sometimes in patients with juvenile polyposis. Of course, patients with Crohn's disease or celiac disease can also have an elevated incidence of adenocarcinomas, but they still don't get them very often. Okay, so we're back to our Lynch. We already know that can give you some small bowel adenocarcinoma. I'm sorry, that was our FAP, not a Lynch. But on the other hand, this is a resection from a patient with Peutz-Jeghers syndrome with lots and lots of polyps. You can see the little appendix saying hello. And then you've got all this mess over here, and this one proved to be a carcinoma. And here it is at higher magnification. This ulcerated area was a carcinoma. And then, of course, there are just tons of polyps. So small bowel adenocarcinomas are most common in the duodenum, and about 65% are periampullary. And the incidence decreases as you go through the plumbing. Of course, the exception would be Crohn's disease, and you see that in the ileum because that's where the injury is. And then in celiac disease, you see it in the duodenum. So the problem is if you see something malignant in the small bowel, the chances are 2 to 1 that it is a metastasis and not a primary adenocarcinoma. And there's several very nice papers that talk about this. So I will now state the obvious, just call me Captain Obvious. So here are some things that favor metastatic spread. Multiple lesions, okay. The absence of a precursor, okay. A bottom-heavy appearance to the cancer and a lack of ulceration. And this paper isn't exactly on that, but I refer you to it because it just does such a nice job of talking about the immunostains that can help you. It's by Andrew Belizzi, who is just a very good geek about finding the best immunostains and knowing the most about them. All right, so I want to make an important point. This is a sarcomatoid carcinoma that's involving the small bowel. And you can see that it's spindly. And even this sarcomatoid carcinoma has this capacity to colonize the epithelium. So this is the pre-existing epithelium, and this sarcomatoid carcinoma has colonized it. Well, no problem. It's obviously different. But if a colon cancer spreads to the small bowel, it can colonize and look like an in situ component. You need to be aware of that. This is higher magnification of that same sarcomatoid carcinoma, and it happened to have been from the kidney. This is an example of a metastatic colorectal carcinoma that has colonized the surface of the small bowel. And it's pretty easy to think, yeah, I could mistake that for an in situ component. It's not, it's fake. The stuff is just crawling up. Here's a little bit of pre-existing, a little more, and then here's this colonization of the surface. And here that other area is at higher magnification. And literally the spread carcinoma just has taken up shop right along the top of the basement membrane. This happens to be a cytokeratin 7 from that particular case. Primary small bowel adenocarcinomas like to co-express CK7 and CK20, whereas spread from colon cancer typically lacks CK20 or CK7 expression. And here's the CK20. The newer kid on the block, of course, is SATB2, which is far more likely to stain colorectal than small intestinal carcinomas. Okay, here's a sneak ball ampullary biopsy. Looks like nothing. This is pancreas cancer. Y'all know those pancreas cancers that can look very bland. And in fact, this is small bowel, and this pancreatic cancer component has colonized here. Here's an unauthorized gland. These guys lives here, don't know about this one. This guy doesn't live there. And they're very, very subtle, and they love to partially involve a gland. So here's this area at higher magnification. Pre-existing small bowel. This is the pancreas cancer that's just taking up shop right along the basement membrane. That's pancreas cancer. That's not. Very, very bland. So, and I know people who do ovary will see this in the ovary, and it's so sneaky. All right, so if you're lucky, the pancreas cancer that spreads wherever will have loss of DPC4 or SMAD4, but only 60% of the time does this phenomenon help you, and you'll look for nuclear loss. So here's a nice example of pancreatic adenocarcinoma that has spread to the surface of the small bowel, and you have this beautiful nuclear loss of SMAD4. Naturally, of course, I chose one that worked perfectly to take a picture. Often it doesn't. Okay, is this carcinoid? It's a little off. Well, this proved to be metastatic melanoma. So things really are very sneaky in the small bowel. Now, if you're not in the habit of checking the lacteals, you would miss this metastatic breast cancer. This is another pancreatic ductal carcinoma that's, again, colonizing this surface. So just a very important phenomenon. This is not in situ. This is just cancer. And here it is at higher magnification. And there it is, taking up shop. So this is just for fun. Luckily, this particular pancreatic cancer didn't express CDX2. So this is a CDX2 stain that really nicely shows the distinction. And here it is at higher magnification. Mucinous neoplasms. Be careful if you see them on a duodenal or ampullary biopsy. You cannot tell if they are pancreatic or biliary carcinomas that have spread onto the top of the ampulla, or whether they're intraductal papillary mucinous neoplasms that have just kind of spread up onto the surface. Don't try, because they're going to do an operation anyway. So you don't have to make a fool of yourself, and you do need to express in your report the need to correlate with pertinent imaging. There's going to be similar operations, and they can tease it out much better. So this is a beautiful example. We saw a similar example this morning from Dr. Khaled, and you can see this nice small bowel coming in, and then there's all this rubbish here. But it's coming from this IPMN, intraductal papillary mucinous neoplasm, that's extended all the way onto the surface. And it really mimics a peculiar adenoma. So just a very interesting case. This is what the top of such a lesion might look like. It's not that particular case. So you'll remember I showed you the gastric mucin cell metaplasia. This doesn't look like that. It's disorderly. It doesn't have those organized four lines. And the mucin has kind of a peculiar purplish color on hematoxylin and eosin. So this is not fake. This is real. The trouble is that you cannot be 100% sure whether this is a carcinoma or an IPMN that's colonized. I would suspect this is an IPMN, but I would write the report carefully. Okay, now we're going to switch gears to the joy of mast cells. So the joy of mast cells. So here are some things that have been that involve mast cells. There's something called mastocytic enterocolitis, something called systemic mastocytosis, and then there's our friend, the mast cell activation syndrome. And these are all an example of a little knowledge is a dangerous thing. So mastocytic enterocolitis was described actually by a wonderful pathologist who worked at Rush, Dr. Jacate, and he's just the most wonderful man. But this was not his best paper. So he and some gastroenterology colleagues took patients who had diarrhea predominant IBS, took biopsies, did mast cell stains, and found, oh, they have more mast cells than other people, except nobody else has found that. And they gave them antihistamines and things to settle down the mast cell mediators, and the patients felt better. Okay, so it became a thing. And then we began being asked every minute, it was 2006, I believe, that paper was published, to get silly mast cell stains. Then there's the other two. So let's kind of go through them. Okay, so as I mentioned, in mastocytic enterocolitis, the colleagues took diarrhea predominant IBS, compared the counts in patients without it, and found that there were more than 20 mast cells per high power field in many of the patients. They felt better if you gave them cromolyn sodium, and they responded to H1 and H2 antagonists. Okay, great. But I'm sure all of you who are a bit older remember the daily requests for silly mast cell stains. That paper has been completely debunked. In 2014, however, with the senior author, Jason Hornick, who does mostly soft tissue pathology, but he's just an excellent pathologist. He also does GI, and Leona Doyle is the same way. And they basically did the homework, and I'll circle back to their raw data. And they found that mastocytic enterocolitis was rubbish. Okay, what is systemic mastocytosis? Well, it's a clonal neoplastic proliferation of mast cells, and it can involve one or more organs. And there are different subtypes that are recognized by paying attention to the clinical manifestations and the distribution. So the classic one, of course, is urticaria pigmentosa that involves the skin, but you can also get a fancy one called telangiectasia macularis eruptiva perstans. I am not scholarly about that. There is a diffuse cutaneous mastocytosis or even a solitary mastocytoma. These are neoplasms. And then in systemic mastocytosis, you can have an extracutaneous type. And if you have that type, the bone marrow is the usual thing. So our hemopath colleagues are pretty good at assessing for it in bone marrow. On the other hand, you can have systemic mastocytosis in which the actual lesional cells are in the GI tract. Even if a patient doesn't have GI involvement, though, the poor patient can still have horrendous GI symptoms because of all the mast cell mediators like histamine and leukotrienes that your mastocytoma here puts those out, but that makes you have diarrhea, even though the cells aren't there. So in patients with involvement of the GI tract, the symptoms can either be a reflection of direct infiltration of the mucosa by the lesional mast cells, with malabsorption and horrible local mediator release, or it can be systemic. So the frequency of GI symptoms in patients with systemic mastocytosis is estimated at about 70%. If they only have skin lesions with no GI lesions, it's only about a quarter of them that have GI symptoms. So this is a normal colon, and this was from this was just from a patient who was just having polypectomies, and we just did it for fun on one of the slides, and you could easily get to 20 per high power field, and the patient didn't have any diarrhea. This is just higher magnification in another area. This, on the other hand, is the mucosa, I believe this was colon, in a patient with systemic mastocytosis, and you can see this is all edematous and almost polypoid, and looks absolutely miserable. And here is, I don't know if this is that patient, but this is another patient. This is small bowel, here are the Brenner glands. And you see this kind of cleared out area. I hope everybody spots it. And that's where you look for the naughty guys. And you can see it looks like that in the colon too. You pick it up on low power. You just see this area that's kind of cleared out. And at higher magnification, it doesn't look like much, but the mast cell nuclei tend to be elongated and they draw eosinophils. So you almost always see a lot of eosinophils in these patients. Here's a very easy one. You don't have to be clever to notice that there's something wrong here. Again, though, they're supposed to be amphiphilic, but the cytoplasm's kind of clear. And this one doesn't have that many eosinophils, but there's a few up here. So this one's quite easy to pick out. On the other hand, this is how it often looks, and you can learn to pick it out. So this is regular lamina propria, and this is the stuff that's affected. And there's kind of a clearing here, and it has a different density from the bottom. I just pick them up because I just see that peculiar appearance towards the top. Now at higher magnification, we can see the systemic mastocytosis with the oval-shaped nuclei and the backdrop of eosinophils. So if you do a kit, this is how it looks in the real deal. They're just sheets and sheets of mast cells. This happens to be a CD25 from one of the cases I just showed you. It's a finicky stain. It's supposed to be membranous. I had to diddle around with this in Photoshop to get it to show well. So you really have to kind of go to high power and study it. And notice I diddled with Photoshop so much that I turned the mucosa a little bit positive. But I think you can see that the mast cells have this membranous staining. Here's the tricky one. This looks like it's all eosinophils, but as you kind of carefully look, you'll notice that there's a rind around the glands, and those are your mast cells, and they've just called out their eosinophil chemotactic factor and all that other rubbish they put out. So come on, guys. And so here are all the eosinophils. Here's the kit from that case. Isn't that amazing? All right, so that's what you see in the real deal. There are rare instances in which you can see that pattern. The patient's completely asymptomatic and really can't be proven to have systemic mastocytosis. But if you see the patterns that I just showed you, obviously the patient has to be worked up. So you definitely don't want to miss it. Here's the one that our clinical colleagues often are asked to address. I think the gastroenterologists will get asked by allergists to take colon biopsies to rule out mast cell activation syndrome. So they're kind of like the monkey in the middle, and the allergist hasn't bothered to read the papers. So what is mast cell activation syndrome? Well, essentially, these folks have mast cells that are just having a party. They're not neoplastic, but they somehow just become activated. So how might that happen? Suppose, you have a prosthesis and it rubs all the time and gets your mast cells jacked up. Or you have an autoimmune condition that just activates your mast cells. Or you are crazy and you itch yourself all the time. Some neoplasms can even release mast cell mediators, and then all this can be defined as secondary mast cell activation. That would be the secondary from a neoplasm. But generally, it's just mast cell activation. It is non-neoplastic, but somebody's mast cells just go crazy and put out their mediators, and it causes symptoms. So this is from one of the Mast Cell Activation Society papers. Let's see, this one was 2013, but they did another set of criteria in 2019, and they had this same table. So look at it and see how it's diagnosed. What's not on there? GI biopsies. They're not on there. That's not part of the workup. Bone marrow biopsies are sometimes indicated, but really what they need to do is they have to do all these serologic studies for these abnormal mast cell mediators. And of course, they have to make sure there's not a neoplasm. Is it terrible to do biopsies in the GI tract and make sure there's no systemic mastocytosis? Of course not. But if you don't see that, you still haven't done anything to address mast cell activation syndrome. And a lot of people say it's just silly to do mast cell stains in normal mucosa. So the more recent guidelines, as I've alluded to, had that same picture, and they didn't include GI biopsies. So there was a 2011 study, which is one of the earlier studies by Dr. Hamilton, who's very scholarly about this. And when he did counts, he didn't find any significant difference in the numbers of intestinal mucosal mast cells between patients with this syndrome and healthy controls. So I try to avoid wasting the patient's money on a whole bunch of silly stains if I can. But sometimes colleagues are very emotional about it. So this is now the paper that I alluded to from Leona Doyle and Jason Hornick about this so-called, they were talking about systemic mastocytosis, but they compared mast cell counts in mast cell activation syndrome, diarrhea predominant IBS, and asymptomatic patients. And you can see that maybe it's a little less in the asymptomatics, but basically it doesn't meet statistical significance. So these patients essentially have superimposable mast cell counts. So this is a very nice paper. It is from 2014. It's not new, but I don't think things have really changed. Now, there are a couple of cautions, as I mentioned. So there's a paper actually from Rhonda Yantis with Melanie Johnsilla as the first author. And they did find some cases in which there were globs of mast cells, but the patients really could not be shown to have systemic mastocytosis. And there's a very rare condition called hereditary alpha tryptosemia, and it can produce mast cell clusters at the tips of intestinal villi. So if I am browbeaten into doing silly mast cell stains, we'll have a discussion and say, you know, we really don't get any more information doing mast cell stains in histologically normal samples. But then sometimes colleagues are really browbeaten into it. And then this is what I say. A CD117 shows normal distribution and density of mast cells. There are no features of systemic mastocytosis. So-called mastocytic enterocolitis has been called into question, together with the utility of mast cell counts in histologically unremarkable samples. And then I give them all these nice references. But of course, obviously, if someone's sick as a dog, is it terrible to do mast cell stains and just make sure you're not overlooking something? Of course not. But we don't want them to think, oh, the patient has no mast cell activation syndrome because there aren't extra mast cells in the GI tract. So this is what I do with these. All right, so I'm going to close with a note of caution, and I like to share this case, so I apologize if you've witnessed me sharing it before, but this is a case that I screwed up in around 2005, and it's just something you don't want to do. Don't do what I did. Okay, so a young guy presented with vomiting, and he had a great big duodenal mass. It was biopsied in around 2005, and here's how it looked. I got a bunch of immunostains, but not the right ones. And it was CK7 positive, and it was CK20 negative. Okay. So I wrote a report that said poorly differentiated carcinoma involving the small intestine. Please correlate with imaging to address the possibility of other disease sites. So I did okay by the letter of the law, not so well by the spirit of the law. So yes, this was technically correct, but not helpful. Okay, so there was a long delay until the boy got the correct diagnosis, and it proved to be an embryonal carcinoma, and it had its primary in the retroperitoneum instead of the testis or mediastinum. But I should have just done a darn stain to address a germ cell tumor right up front, but I didn't. Well, I learned this was another embryonal carcinoma that came another while later, and this time I was on it. This was a teenage boy. Nope, you're not going to screw that up again. You already did that. But notice it even has like a mimicking in situ component kind of thing here. I don't think any of us would call this an adenoma, but really you have to think of it if it's a young guy. Okay, so I learned my lesson, and then here's somebody else's dirty laundry along the same theme. Another young male patient had a duodenal mass, and the colleague had signed it out as Ewing sarcoma. Here it is. And Ewing sarcoma has been reported in the duodenum, and I can't say I've seen hundreds of cases, but I've seen tens of them. And here it is, this lesion. Okay, so hopefully some of you are saying, no, there's something off here. Ewing sarcoma should have very, very, very monotonous cells and shouldn't have any pleomorphism. And oh, this has inflammatory cells admixed. Here it is, pleomorphic. And this was at the site of it. So I'm sure anybody who does certain types of pathology is very onto what this is. So the colleague had done a CD99 and signed it out as Ewing's / primitive neuroectodermal tumor, and the patient was given appropriate chemotherapy, but didn't seem to be doing well. Then I got it. I did this stain. It's a CD117. And then I did this stain. Oops. And I did this stain. So I'm sure most of you know this was a seminoma. And of course, when they carefully studied this, this boy's physical exam, he had a very, very tiny testicular mass that had probably regressed and then busted out and spread to the small bowel. So by then I had learned my lesson and I made a proper diagnosis immediately. So please remember that lesions from other sites outnumber small bowel primary neoplasms by twofold. Always consider reparative interpretations before you diagnose adenomas. And with that, I thank you.
Shuts it
definitely had our share of obsession with Mastocytic activation syndrome. With, some of our clinical colleagues here were obsessed with it.
Yes, but they respond to education.
Well, that's a different story.
So what do? Do you just sort of, if they really fuss, you say, fine, we'll make sure it's not something we've overlooked and then take it from there?
Eventually they left.
Okay. Okay. I mean, you don't want to miss systemic mastocytosis, but you can see it on the H&E. Something is off. And I will confess, occasionally I've sort of worried myself about it and then done a kit, but that's a little different. So, and been wrong. Okay, any other comments, questions?
I have a comment about the viewings. I mean, it's astounding that they didn't do fish for ETBell translocation. And I'll tell you a big warning flag is that if you ever get a case called fusion negative viewings, all the lights on the dashboard ought to go off. Because what fusion negative viewings usually turns out to be is the tumor that hasn't been fully worked up. And CD99 alone is not specific for viewing. It contains all sorts of stuff.
It does,
Yeah.
including T-cell lymphomas or T-cell leukemias. But yeah, so I don't know quite how that went. Any other questions, comments? Y'all have had enough. It's been a lot of talks today. Yeah, all this.
Thank you. So thank you very much, Dr. Montgomery. So that was the last presentation for today. And we were monitoring the chart just to see. So there's one question that came in: how to morphologically suspect serrated polyposis syndrome and MYH. I guess that meant MOT-YH polyposis syndrome. And so usually most of the MOT-YH polyposis are typical adenomas. So they actually, sometimes you think about them as an attenuated form of FAP. So, and the other serrated polyposis syndrome, of course, are just serrated lesions, not adenomatous lesions. So that's the difference. Okay, so a couple of housekeeping things. Tomorrow, the MSP meeting continues and registration starts from 8 o'clock. And yeah, so there's going to be some announcements about that. And the other thing I need to remind you, you're going to get a reminder email about the evaluation, but the link is here. So try and submit your evaluation about the ETBell. Those are two separate meetings, by the way, so that there will be a separate evaluation for the MSP. And then, of course, there will be instructions on how to claim your CME for every attendee. So Dr. Khalifa.
Well, thank you. Thank you all for your attendance, and I hope you enjoyed these sessions, and I hope to see you tomorrow. As Deli said, please don't forget to provide us with your feedback. Evaluation is very important for us. Before we close the day, I think we need to give due credit to those who work behind the scenes to make this happen. We could not have done this without Rosemary's help. She's back there. And this year, Tony back there, he was the man. I told him, those of you who witnessed the disasters we had last year, because I was the IT guy, it was rough. So thank you, Tony. You did a great job. And thank you all. Good night.